An ulcer is an unhealed sore or open wound that might appear on the skin or mucosal surfaces due to destruction of the epidermis that extends into the dermis, and might reach subcutaneous fat or deeper tissue. Skin ulcers might take a very long time to heal. For optimal wound healing, the wound bed needs to be well vascularized, free of devitalized tissue, clear of infection, and moist. The general approach to treating any ulcer starts from wound debridement to remove the accumulation of devitalized tissue, as well as decreasing the bacterial load to prevent infections. This is usually done through irrigation, typically warm isotonic saline solution, where surgical debridement with a scalpel or other sharp instruments is done for removing large areas of necrotic tissue, as well as for chronic non-healing ulcers or when there are signs of infection. In addition, individuals with infected ulcers should have wound cultures sent and should get started on antibiotic therapy. Then, a dressing is applied to the ulcer to help the wound heal more quickly by providing a sterile, breathable, and moist environment, as well as reducing the risk of infection. Dressings are typically changed daily or every other day. Non-healing ulcers might progress to gangrene, which is a hard, dry texture, usually in the distal toes and fingers, often with a clear demarcation between viable and black necrotic tissue. When gangrene has set in, amputation of the limb might be required. Skin ulcers most often appear on the legs and can result from multiple causes. Biopsies are not usually necessary for most ulcers, but can be helpful when the diagnosis is uncertain. The most common causes are venous insufficiency, arterial insufficiency, and neuropathy. So they're often classified as venous, arterial, or neuropathic. Venous ulcers are associated with venous insufficiency due to valve dysfunction, which causes stasis of blood in the legs, and that leads to an increase in venous pressure. This in turn allows blood proteins and fluid to leak into the interstitial space. Over time, this increases the pressure in the tissues and can cause tiny capillaries to get pinched shut, ultimately leading to tissue ischemia and subsequent breakdown of the tissues, including the skin. Some risk factors are being older, female, obese, pregnant, and standing for a long period of time. Venous ulcers are usually shallow with irregular borders and overlying yellow, fibrinous exudate. They're usually on the lower leg, on the gaiter area of the leg, which extends from the mid-calf to the ankle, or on the medial malleolus, and they can cause mild to moderate pain. There might be associated signs like edema, varicose veins, and brown discoloration of the lower legs and feet due to hemosiderin deposition. There might also be stasis dermatitis, or lipodermatosclerosis, which is erythematous induration and fibrosis of the lower medial leg, which can also be painful. If the diagnosis is unclear, or if surgical intervention is being considered, then non-invasive venous imaging with duplex ultrasonography can be done to assess reflux and obstruction in the superficial, deep, and perforating veins. Treatment options include manual compression to help increase blood flow, as well as compressive bandages and stockings, and frequent periods of elevating the legs above the heart. Surgical treatments are used in severe disease, and they include vein transplant, vein repair, or vein removal. Arterial ulcers, also known as ischemic ulcers, are typically associated with peripheral artery disease, where the ischemia is due to occlusion of an artery leading to reduced blood flow to the tissue, leading to tissue necrosis and ulceration. Risk factors include diabetes, smoking, hypertension, and hyperlipidemia, all things that damage the arteries in general. Arterial ulcers often begin as minor wounds that fail to heal because the blood supply doesn't meet the increased demands of the healing tissue. The lesions are often dry and painful, but with little bleeding. Arterial ulcers tend to occur on the lateral side of the leg and over bony prominences, like the toes or pressure areas like the heel, malleoli, and shin. Often there's a shiny appearance to the skin, local hair loss, diminished pulses, brittle or rigid nails, and the ulcers sometimes get infected. Non-healing ulcers might progress to gangrene. Peripheral arterial disease can be diagnosed with ankle brachial index, or ABI testing, which measures the ratio of systolic blood pressure in the ankle to the systolic blood pressure in the upper arm. ABI range of 1 to 1.4 is what's considered healthy or normal. Values of 0.91 to 0.99 are borderline, and values lower than 0.9 are considered to be due to peripheral vascular disease. For treatment, arterial blood flow must be reestablished with revascularization. Options include percutaneous intervention, surgical bypass, or a combination of these. Neuropathic ulcers happen when individuals have damage to peripheral nerves involved in sensation, causing a peripheral sensory neuropathy. There is often reduced sensitivity to touch, temperature, and pain, and it most often involves the longest nerves, which are in the lower legs and feet. Feet often get damaged by thermal or mechanical trauma, and the tissue breaks down and can get infected. Neuropathic ulcers have a punched-out appearance, usually occurring over pressure points on the foot or heel. But unlike arterial ulcers, they're painless with decreased sensation in the area. The most common cause of neuropathic ulcers is diabetes mellitus, which also impairs the wound healing process. Steps to prevent diabetic foot ulcers include tight glycemic control, good foot hygiene, diabetic socks and shoes, as well as daily foot inspections. Other causes of peripheral neuropathy include spinal cord disorders like injury or spina bifida, alcohol abuse, nutritional deficiencies, and autoimmune diseases. Neuropathic ulcers often go unnoticed until they're pretty advanced, so they often need debridement of non-viable and infected tissue, revisional surgery on the bony architecture, vascular reconstruction, and graft options for soft tissue coverage. Often, amputation of the limb is required. Now, in addition to venous, arterial, and neuropathic ulcers, there are also some less common causes of leg ulcers, like pressure, infections, pyoderma gangrenosum, skin cancer, and certain medications. Pressure ulcers, also known as bed sores or decubitus, usually occur over a bony prominence on the lower extremity, often at the heel, as a result of pressure applied to soft tissues, which causes either a complete or partial obstruction to blood flow. They usually develop in individuals who aren't moving about, like those on chronic bed rest or consistently in a wheelchair. That's why it's important for individuals at risk to have redistribution of pressure by regularly repositioning. Now, some ulcers are due to infections. Here, it's important to figure out if the infection is the cause of the ulcer, so a primary infection, or if it's secondary to chronic ulcers due to other causes. Lesions caused by methicillin-resistant Staphylococcus aureus, or MRSA, often turn into larger abscesses, cellulitis, or ulcerative necrotic plaques. On the other hand, infection by Streptococcus pyogenes produce punched-out, shallow ulcers, with a purulent necrotic crust and surrounding erythema. These lesions are called ecthyma. Immunocompromised people might develop Pseudomonas aeruginosa infection, which can cause ecthyma gangrenosum, which is gangrenous ulcers with black eschar, which is due to dead tissue. Other causes of infectious ulcers include atypical mycobacterial infections, late-stage syphilis, fungal infections like coccidioidomycosis, blastomycosis, or histoplasmosis, and protozoal infections like leishmaniasis. The diagnosis of infectious ulcers requires identification of the causative organism via swab or tissue culture, and treatment varies based on the pathogen. Pyoderma gangrenosum is an uncommon inflammatory and ulcerating skin condition that's often associated with an underlying disorder like inflammatory bowel disease, arthritis, or hematologic malignancy. Initially, there are small pustules that rapidly progress to painful leg ulcers with purulent drainage, necrotic borders, and surrounding erythema. The ulcers usually develop on the lower leg, and there's often fever and leukocytosis. Pyoderma gangrenosum is a diagnosis of exclusion, and ultimately if a biopsy is done, it might show neutrophils accumulating in the dermis. Individuals with mild, localized disease get initial treatment with a high-potency topical corticosteroid, or topical tacrolimus. And those who fail to improve get systemic immunomodulatory therapy, often with dapsone or minocycline. Individuals with more extensive or rapidly progressing disease get initial treatment with systemic glucocorticoids or cyclosporine. Most individuals with pyoderma gangrenosum who are treated see improvement in a year, but relapses can happen after long periods of disease remission. Various skin cancers can also cause ulcers, including squamous cell carcinomas, basal cell carcinomas, and melanoma, but also soft tissue cancers like leiomyosarcoma, cutaneous lymphomas, and Kaposi's sarcoma. For these, it's helpful to get a biopsy to rule out a cancer for ulcers that are enlarging or failing to heal despite treatment, occurring in scars, or with exophytic or irregular wound edges. Last but not least, some medications can cause leg ulcers, including warfarin, heparin, and hydroxyurea. Here, the first step is to discontinue the offending medication. Warfarin-induced skin necrosis is a microvascular occlusion syndrome that begins 2 to 5 days after beginning warfarin therapy, without concomitant heparin therapy, and develops because there's a transient hypercoagulable state. Pain is the initial symptom, followed by erythema, which then becomes hemorrhagic and necrotic. Warfarin-induced skin necrosis most often occurs in fatty areas, like the breasts, hips, buttocks, and thighs. Then there's heparin-induced thrombocytopenia, which is a thrombotic complication of heparin therapy resulting from the production of autoantibodies against platelet factor IV in complex with heparin. Individuals with heparin-induced thrombocytopenia can develop microvascular occlusion, resulting in skin necrosis at sites of heparin injection or other sites, like the distal extremities or nose. The initial manifestation is erythema that evolves to purpura, hemorrhage, and necrosis. There might be a falling platelet count, and it can even happen if the heparin has already been discontinued. Finally, individuals receiving chronic hydroxyurea therapy might also develop painful chronic ulcers on the anterior lower leg near the malleolus. Classically, the ulcer has a surrounding area of scar tissue called atrophy blanche, which develops when there's a poor blood supply and slow wound healing. Alright, as a quick recap. Venous ulcers are usually shallow with irregular borders and overlying yellow, fibrinous exudate. Individuals might have mild to moderate pain. There might be associated signs like edema, varicose veins, and brown discoloration. Treatment options might involve manual compression to help increase blood flow, compressive bandages and stockings, and elevating the legs. Surgical treatments that can help cure individuals with severe disease include vein transplant, vein repair, or vein removal. Arterial ulcers are painful, often appear dry, and tend to occur over bony prominences or pressure areas. Associated clinical findings might include a shiny appearance to the skin, local hair loss, diminished pulses, and nail changes like becoming brittle or ridged. For treatment, arterial blood flow must be reestablished with revascularization. Options include percutaneous intervention, surgical bypass, or a combination of these. Neuropathic ulcers usually occur over pressure points, but they're painless, so they often go unnoticed until they're pretty advanced. The most common cause is diabetes mellitus. Steps to prevent it include glycemic control, good foot hygiene, diabetic socks and shoes, as well as daily foot inspection. Often, amputation of the limb might be required. If venous, arterial, and neuropathic ulcers have been ruled out, we might start thinking of other, less common causes of leg ulcers, like pressure, infection, pyoderma gangrenosum, skin cancer, or medications.